Thank you, Dr. Martini, for that generous introduction. So these are my disclosures. So I hope in the next 20 minutes to cover these 5 myths. First of all, that heart failure with preserved ejection fraction, otherwise known as HFpEF, is not as serious as HFrEF. Number two, that it is easy to diagnose. Number three, that HFpEF is due to a stiff heart. Number four, that there are no treatments. And number five, new approaches are limited. And I want to emphasize these are all myths because I believe each one of these points I just stated is wrong. So, to move along, HFpEF is clearly serious. There's a lot of evidence to suggest this, both epidemiologic and otherwise. So, for example, we know in the US that the prevalence of people being hospitalized with this condition is growing, and it has and will continue to surpass people who get admitted with HFrEF or heart failure with reduced ejection fraction. This is some epidemiologic data that was actually reported several years ago and speculated that we would see HFpEF surpass HFrEF, which has come to be true. Number two, patients with this condition have significant impairment of quality of life. These are two data sets that suggest that patients with HFpEF, in fact, do not feel well and have exertional intolerance. On the right, you see the oxygen consumption of HFpEF in green compared to patients with HFrEF and normal controls in red. And as you can see with exercise, HFpEF patients can only generally triple their basal oxygen consumption, which is quite comparable to HFrEF and very distinct from normal controls. On the left, you see the quality of life scores of patients with HFpEF from a large clinical trial in HFpEF called TopCat. And as you can see here, that a significant number of these patients have very poor functional and quality of life metrics. So let's move on. Do you know it when you see it? It is often thought that this is an easy diagnosis to make. I'm going to explore with you some challenges that we have. So for example, look at these 4 patients. These are all patients that I've seen over the years, all who are short of breath, all have a normal ejection fraction on echo, and have no coronary disease or valvular abnormalities known. Do these people have HFpEF or do they not? The first patient is a 55-year-old man with a very high BMI, high blood pressure, and swollen legs. The next patient is a 70-year-old African-American man, again with obesity, hypertension, diabetes, arthritis, and LVH. The next patient is an elderly woman with atrial fibrillation, anemia, and left atrial enlargement. And the last patient is an elderly African-American man with chronic kidney disease, COPD, and pulmonary hypertension by echo. Now, do these patients have HFpEF or do they have something else? And how would you figure that out? Well, the first and most important lesson is that, unfortunately, signs and symptoms of HFpEF are not unique to this diagnosis. And so when you see patients that have signs and symptoms of heart failure, such as swollen legs, shortness of breath, etc., you have to think about the differential diagnosis. There are other causes of volume overload, shortness of breath, and swollen legs. And these things include cardiac conditions on the left, as well as non-cardiac conditions on the right. So it's very important to consider a wide differential diagnosis. But at the end of the day, particularly for clinical trials, the way we make the diagnosis to get into the study is that you have to have symptoms, shortness of breath, paroxysmal nocturnal dyspnea, orthopnea, and you have to have a sign, and most of these signs are signs of volume overload or what we call congestion. Elevated venous pressures, edema, chest x-ray, or even a blood test suggestive of congestion, such as a BNP or a heart failure hospitalization. But keep in mind that some of these challenges extend to the measurement of ejection fraction. To be diagnosed with HFpEF, you really should have an ejection fraction of greater than 50%. But even trying to figure out whether your ejection fraction is 50% or not can be challenging. This is work from a clinical trial here that just demonstrates that the ejection fraction in the clinical sites here in orange were thought to be less than 35%. But when those echoes were reread by a core lab, you can see the ejection fraction extends from 20 to 60%. Moreover, we understand that the findings on echo are quite heterogeneous. For example, in the TopCat trial, where a subgroup of patients had core lab echocardiography, you see nicely that the ejection fraction is quite high, but what you find is there are very heterogeneous findings on these echocardiograms. For example, LVH is actually present in the minority of patients. Number two, left atrial enlargement, it was only seen in half. And pulmonary hypertension in only a third. So echocardiography, although important, it can be challenging to incorporate into the diagnosis of HFpEF. How about natriuretic peptides? We do know that BNP can be very useful in the shorter breath patient. The problem is in HFpEF, sometimes the elevation of BNP is very modest. And number two, because many obese patients have HFpEF, the BNP may not be elevated at all. And the reasons for this are many, but one important reason why natriuretic peptide levels are not elevated in HFpEF is because wall stress is low because of the ventricular hypertrophy. And there are many other reasons why natriuretic peptides levels are low in HFpEF, but you have to be very careful about using natriuretic peptides as your sole diagnostic criteria. I prefer this current risk factor approach, and this is called the H2PEF score. And by using clinical variables, you can decide in a given patient whether they are at high, intermediate, or low risk for having HFpEF. If they are at low risk, then you can probably move on. If they're at very high risk, then the diagnosis is very reasonable. It's those patients in whom have HFpEF scores in the middle, having a probability of HFpEF, you see there at the very bottom, of somewhere between 0.3 and 0.8, or a score somewhere of 2 to 6 or 2 to 5, where the diagnosis is uncertain and you might want to consider other diagnostic studies such as a right heart catheterization. As you can see here in this particular study, the C statistic was quite good, 0.84. What is my approach to the short of breath patient? Well, my approach is to do this. If there are clear signs of volume overload, venous hypertension, clear volume overload in the legs, as well as symptoms such as orthopnea or PND, and the ejection fraction is normal, and most importantly, you've excluded other causes like constriction, pulmonary hypertension, or even anemia, then you can be comfortable that this is a condition of HFpEF. In a patient without volume overload who's short of breath, it's much trickier. And in this situation, we often have to use provocable studies to demonstrate that there's an elevation in filling pressure. This can be done in the cath lab or the echo lab. All right, let's move on to my next myth, that HFpEF or heart failure with preserved ejection fraction is due to a stiff heart. This concept has been around for a very long time, but I think as many people on this call recognize, this is really a very heterogeneous syndrome. And many studies have borne out that the mechanisms responsible for exertional intolerance and fluid overload really span a spectrum of causes, everything from stiff heart to impaired vasodilatory reserve. EF may be normal, but systolic function may be actually abnormal. There's chronotropic incompetence, etc. There are a number of things that are likely responsible. And many people feel that the heart is actually an innocent bystander in a systemically dysfunctional environment driven by comorbidities, such as hypertension, diabetes, chronic kidney disease. And these are all ganging up to produce the syndrome. What I do want you to think about, though, is that when you see a patient with HFpEF, as I already alluded to, there's a differential diagnosis. And that differential diagnosis also extends within the spectrum of HFpEF. And there are 2 or 3 diagnoses I always want you to think about when you see a patient that you've made a putative diagnosis of HFpEF. Number 1 is consider the diagnosis of amyloid. This is autopsy work from the Mayo Clinic, in which they demonstrated that patients at autopsy with the diagnosis of amyloid commonly had amyloidosis. And we believe now that maybe as much as 5 or 10% of all HFpEF patients, in fact, have amyloid. And I think you should think about this diagnosis particularly in elderly men with very high BNP levels and no hypertension. So again, if you see a HFpEF patient who's male, elderly, no history of high blood pressure, and a very high either NT-proBNP or BNP, you need to think about amyloid. Number 2, exertional intolerance. Now, chronotropic incompetence, or the lack of ability to raise your heart rate with exercise, usually doesn't cause fluid overload. There is some data that it can produce an elevation of filling pressure, but it certainly can cause exertional intolerance. This is work from Johns Hopkins that simply shows you that those patients with HFpEF can't exercise as far, their peak heart rate is attenuated, and their heart rate recovery, meaning that how quickly their heart rate returns to baseline, is quite slow and prolonged as opposed to controls. And of course, the therapy here is to stop the beta blocker, and if that doesn't help, even pacing can be considered. And then finally, there are the obese patients, and this represents a very important subgroup of HFpEF patients. This is a very complex situation, but we believe in some of these patients with HFpEF and obesity, this is due to what we call high output heart failure, very similar to, for example, the heart failure of anemia or thyrotoxicosis. As you can see in this work from Barry Borlaug from the Mayo Clinic, in red, the patients with obesity and high output heart failure have elevations in wedge that are much higher for the systemic vascular resistance seen in panel B than you would anticipate, and also that they have a high cardiac output relative to wedge, as you can see in panel A. Well, let's move on. Let's move on to treatments, because at the end of the day, I think everybody's listening to this 20-minute talk, because when you see these patients, you want to know what to do. Well, you know, this has been challenging. This is a summary slide from more than 20 years of randomized, prospective, controlled trials in HFpEF. And in this particular timeline, positive trials are above the dotted line and negative trials are below the dotted line. And as you can see, basically we've not been able to discover any significant positive trial. But I do believe that there are 2 exceptions to that, and I'm going to get to that in just a moment. So this has also been reflected in the guidelines. If you look at the AHA-ACC guidelines on how to treat this, and now we're actually redoing these guidelines as we speak, but in 2013, when this was last addressed, the only 2 class 1 recommendations you see there in green for the treatment of HFpEF is 1, control the blood pressure, and 2, use diuretics. Now, I don't know about you, but those are not exactly very compelling recommendations to control blood pressure, to use diuretics. But at the time, that really was all we had. What I would like to review with you are 2 therapies that I think all of you should consider in your patients with HFpEF. Number 1 is the use of spironolactone, a mineralocorticoid receptor antagonist. Now, these drugs have been around for a while. They were invented in 1957. And in the TopCat trial, patients with HFpEF were randomized to spironolactone versus placebo. And although the overall trial result was neutral, it appears that there was a tremendous amount of heterogeneity in the study.
Dr. Fang, sorry, 3 minutes more. 3 minutes more.
10 minutes?
3 minutes.
3 minutes. Okay, fantastic. So in the TopCat trial, it would appear that if you looked at the results in the Americas, that in fact, spironolactone was beneficial. The other study I want to actually review with you is the Paragon trial. This was a large trial of the use of sacubitril/valsartan versus valsartan in HFpEF patients. Who was in this study? This was a classic HFpEF population. On the right, you see they were elderly, had a high ejection fraction, had a GFR in the mid 60s, and many were on blood pressure medication. And in this particular study, using the primary endpoint of total hospitalizations and cardiovascular death, you see that the risk reduction was 0.13, 13%, giving a hazard ratio of 0.87. And the p-value here was 0.06, which barely missed. But if you look at actually the number of events, it's all in the right direction, whether or not you look at heart failure hospitalizations or cardiovascular death. Moreover, it made people feel better. If you looked at the KCCQ and NYHA classification, there was clear evidence that these patients felt better. And there were important subgroups. Two subgroups that I'd like to remind you that may benefit in particular are female patients who have an ejection fraction in the lower range of the HFpEF spectrum. Here, the cutoff was 57% because that was the average in this trial. And of course, safety is very important, and these drugs were very, very safe. So my takeaway with respect to what to use, particularly sacubitril/valsartan, I would tell you, although this was technically neutral, there were a large number of events, and the p-value was 0.06. Although there was no impact on survival, it did keep people out of the hospital, and they felt better. And I do think that these important subgroups of elderly females should be kept in mind, particularly when their ejection fraction is at the lower end of the EF spectrum. Finally, I want to cover in the last minute new approaches. I think everybody recognized that sodium glucose cotransporters may help in this, inhibitors may help in this realm. There are two large trials being done right now. Deliver and Emperor Preserved, both have been enrolled fully, and we'll be reporting these out soon. And then finally, I want to mention that it is a heterogeneous syndrome, and at the end of the day, perhaps the way forward is to subtype different types of patients with HFpEF and treat them in these subcategories. So to conclude, HFpEF is as serious as HFrEF. Number two, it can be challenging to diagnose, but I think I've given you some pearls to think about. Number three, it is actually due to many things, including a stiff heart. In terms of treatment, I'd ask you to consider spironolactone and sacubitril/valsartan. And then finally, stay tuned. There are new trials coming. Thank you much for your time.
Thank you very much, Dr. James Wang, for the exciting and nice presentation.